please, thanks present and past honorary members and presidents. It's a deep honor for me to be here, and hopefully we'll get some fruitful discussions. I will start before you are entering deep sleep, bring you to some highlights for my presentation. I think one of the important points here is actually to remember the level of evidence. And speaking about the capping of the pulp, I think there's an aspect that may need some more attention, as we have had no tradition of checking in relation to caries the actual penetration depth. And this might be an important factor in research. I'm not saying that it should be a prime goal in daily practice, because we all know that if we receive a tooth that needs a cap, maybe everything has been removed that have been carious or something like that. But in relation to research, it might give us some new points. And we have tried to divide some of the old interventions in two groups when we speak about the direct cap. And the first one would suggest having a good prognosis due to case selection, normal pulp, no infection in the dentin, and we could call it class 1. As opposed to this, we know now, based on observational data, that you can also apply a quite sophisticated protocol, and maybe only for specialists, but where we are able to see that you can actually cap quite wild cases. Firm evidence for best choice of pulp capping, do we have that? No, and that's why we are here today. We have a lot of unanswered questions. No worries, we will talk about that. So, about level of evidence, you know, a friend of mine, and he's in the audience, he wrote to me some months ago, "Hey Lars, I have some cases, would you like to show them on this day?" "Okay," I said, "give it to me." And then he forwarded me cases where you see capping of the irreversible pulpitis, even with micro abscesses. "Is it possible?" "Yes," he says. "I'm looking in the mic. I take the tiny microtubes, I suck the pus, and I wait for hemostasis, and then I do my job." "Okay," I say. And then he also provided us with some follow-up data, and okay, 2 of the guys left the building, but on this basis you can say that it seems possible to make these treatments. We can always discuss later in the day what happens at the apical region, but it seems possible. So what I'm telling here is that such a study shows what is possible. And you know, within endodontics, we like this. Maybe we do not need anything more. You know, when people talk about RCT, meaning randomized clinical trials, we actually talk about our root canal treatment we made yesterday. Isn't it so? But if we want to push it further, if we want to say, okay, let's turn the hierarchy of pyramid the right way, what is needed to take care of our stakeholders, in the end being our patients? Because, I mean, isn't our goal that a patient should receive the best treatment, whether it's in Holland, Copenhagen, or Singapore? So our case just shown is a classical case control study showing what is possible. Well, if you want to enter the area where you say, okay, could we dare talking about if treatment A is better than B? You need to do the randomized approach. And we have done that in relation to the deep lesion on testing the less invasive excavation procedure against the complete excavation approach. And I think one of the issues in this paper I would like to stress a little bit, because this may be one of the points where we can go further in our understanding what is possible and what is not possible. We tried to select the same type of lesion depth, meaning that, well, the very deep ones we excluded because it may not be fair to compare this in the study design of leaving some tissue behind where you actually could see a perforation into the pulp. It wouldn't make sense. So we focused our data on the quite deep lesion actually, because there's in reality no consensus about what a deep lesion is. But I would prefer or suggesting that we now together define and divide these two categories, because it might be very important in order to understand if a capping works or not. So not to go into deep for the results, we find some differences. Maybe we were expecting more differences as we actually found, but in short, our less invasive stepwise excavation approach showed that we saved pulp exposures significantly, but not widely. But you can say every time you treated 8 cases, 1 pulp was safe. But it was, I mean, studies before this indicated much larger differences. And it also means that we have to know in our world the differences between our interventions might not be that gigantic. And that's maybe also one of the reasons why it's so difficult to gain more evidence, because we need so many patients in each group to show rather low differences. But you can say, now I have to reduce my voice. Okay. So what the data actually is just indicating here is if you repeat the trial 100 times, in one attempt you might only find 0.5 difference in percent, whereas you also are able to find a little bit more, but on the plus side of difference. We also arrived to exposures in this trial, and not that many, but we followed the trial recently for a 5-year follow-up, and what I only want to say in here is that the exposed cases didn't went quite well, a lot of pain and root canal treatment. So comparing to my first case, dealing with the irreversible pulpitis, having microabscesses, versus this scenario where we at all didn't accept those conditions, we actually ended up having perhaps even poorer results. We can't compare, but we can say that it may be a point that we also have to accept. I know it is difficult for us, but we may also have to accept that in 1 or 2 or some cases, the pulp exposure approach might not be the best one to perform if you are not having the extremely deep carious lesion. So the single randomized clinical trial are the one to go for comparison two interventions. You can say there are a Chinese wall of evidence between those two if you want to say treatment A is better than B. So please remember that. So the concept of vital pulp therapy, you could say why saving the pulp or the pulp tissue. Traditionally, maybe you were standing in front of a huge problem with our children, the trauma case, so difficult route to treat on a conventional root canal basis approach. So there was really motivation trying to improve or gain a termination of an incomplete root formation. You could also find survival studies indicating that the vital scenario may in general have a better prognosis. I don't want to drill with the actual procedure. We are all familiar with that. And I actually just want to jump into what we could call our classical grouping of the invasive vital pulp therapies. And there's some years ago there was a quite nice review dealing with the outcome of the direct pulp, and they used what you could say a pooled strategy, and they indicated a certain level of success. But having said that, I really are enjoying another paper that is trying to say, okay, let's try to organize the reasons for why the capping was performed. So again, having the, so to say, normal pulp conditions with mostly non-infected dentin versus a carious lesion exposure scenario, they indicated that you would find quite a huge difference when comparing this. So of course, it only stresses that the potential bacterial pulp contamination is of course very important, whether you're able to control this or not. And also in relation to the carious scenario, you may have a feeling that various progressive stages of carious can have an influence. In short, we must say that the aspect is still quite unclear, mainly due to different study designs. So again, having our hidden agenda in our minds, if we want to improve and if we want to make clinical trials comparing, I think it's nice already now to say that it could be a huge gain if we use the same outcome measure in order to compare our results. We would perhaps never end up having 1,000 patients in each group in one center, but it may be possible to add clinical trials from various centers, and in the end we can say something. But the important point is that we need to have the same outcome measures aligned. But in reality, it may not matter at all, and I've been thinking a lot about the carious lesion depth, and some guys may laugh at me, come on man, this hasn't any influence at all, but actually we do not know. And that's just what interested me, because if it doesn't matter, well, then we can forget about it. So I want to stress, again, in relation to research, it may be quite important. And of course, it also have to link with this stage of pulp inflammation, which will be covered much more with the coming speakers. So just to round up, I don't know is that the right English word, but grouping the direct capping in class 1, I think could be a nice way to manage the situation. Not stressing that the protocol should be less aseptic performed, but it could be that you may not need advanced tools to gain a quite good prognosis. So the normal pulp, and well, I still dare to show that you could use calcium hydroxide, but I also know that you may not use it, but you have to realize that we have quite nice results in the back using that material. But of course, we have other available. But if you are entering the normal conditions and working aseptic, it should be okay and expectable to get a good prognosis. So no big deal. I don't say it's easy. Actually, remember, quite often when we talk of vital pulp therapy, we say, well, it's very easy. So we do this, and the pulpectomy is, of course, more complex. But I think we should go one step back and say, okay, we also have to be aware that we need to control several aspects before we can say this was an easy piece of cake. So the class 2, mainly inspired from George Bogan with his trial together with Leif Backlund. And in reality, it's an inspiration from this protocol. It's sophisticated, meaning that you, and you all know that, you are able to control your movements much better when you do a treatment using the macroscope. And you have perhaps at that time a new stuff by raising the concentration of the disinfection rinsing material may also have an important meaning. And again, the use of the capping material was not calcium hydroxide, but a newer material. And the point here was that he could show results on even extremely deep cases. He had some wording about the state of the pulp still being classically, so he actually did not enter this intervention if the patient arrived with pain and haven't slept all night. Also, being here at this wonderful place, they have made a nice paper actually following this strategy of trying to cap the deep complex scenario. And again, being in this place, I also have another case from now finished specialist, and I'm courtesying Dr. Lee for this very nice case. And also note that we also have some information about the background variables. It says that we do cap younger patients like me. Younger patients, and if we do it on occlusal sites, simulation data indicates that this raises the prognosis, as opposed to doing it on older patients and on proximal sites. It may be more critical in the long run, preventing secondary contamination, perhaps. But even though it failed, quite nice root canal filling, isn't it? So, also knowing that this was case control study, was this possible, and where should we perhaps reduce our ambitions? we are able of treating quite advanced cases, no doubt about that. So taking together an enhanced pulp capping procedure, we could call it class 2, where you need magnification. You could jump and say, this is a specialist treatment. You should consider this as a specialist treatment. And then you can say, in the way we organize our society, how often do we receive a case that should be capped? I have never received one. So there's something here that is difficult. It's quite often in university settings. When I said I have never received one, it was reflecting on my day 1 week where I received referrals. But it's quite often in the hands of the general practitioners or in university settings. Very interesting. Okay, the firm evidence. Have we reached that for pulp capping? And I'm very glad that I can see some of the Norwegian groups having made this very nice paper dealing about the comparison of material in relation to cappings. And they will agree with me that it's hard job doing clinical trials. And they showed that there seemed to be a difference and a better outcome when you use MTA as opposed to calcium hydroxide. And now I will be a little bit cheesy, because if you go into the table, you also realize, and again, it may not matter, but you also realize that the distribution of the severity of the carious lesions maybe was a little bit screwed. Meaning that in the group of the calcium hydroxide, there were a tendency to have much, much deeper lesions. It may not mean anything. It may also shed the real results. But, and first of all, one of the first nice studies indicating the comparison and the potential difference using MTA as opposed to calcium hydroxide in relation to caries. Recently, another trial was launched and presented comparing biodentin with MTA. They didn't find any difference, but they also indicated that the power of the trial, or meaning that we may not have had the proper size of the material to show an actual difference. And that is what we already have indicated being a problem if we want to raise the level of evidence. We also know that this way of changing the material is running fast, and we may benefit a lot of this, but it's also important to know that if we don't test it out in the clinic, it will be a chaotic situation for all the practitioners in order to decide what should we use. So it's always easy to say there's no difference, and does it mean that you can do whatever? Of course not. We also have a realistic feeling of what we gain in our experience with our patients. But I also think it's nice if we have a vision about showing it on the real terms, using rough and robust designs in the clinic. So we haven't reached the firm evidence, and when I use firm, there's actually a quite specific meaning about that, because firm evidence is gained from a research tool where you compare trials and you can make a setup indicating that, okay, now we do not need to repeat that in order to show, let's say, biodentin is the best or something like that. So there is, in the setting of analyzing data, a natural stop, but we can definitely say today that we have not reached firm evidence for best choice of pulp treatment, and also be the reason why we are here today. So about the aspect of unanswered questions, again, dealing with randomized clinical trials, there are several checkpoints, and now you have many references indicating how you should build up the most beneficial protocol, and many groups are already doing that. So I won't detail that. The SPIRIT guidelines, for example, is one of the references that really brings the protocol up to date. I just want to pick up some few cases that could link to, again, the aspect of making inclusion criteria. And again, without repeating myself, I stress that we could perhaps gain interesting data if we know more about the lesion depth of the caries prior making the exposure. Prognostic factors is quite important as being one of the most dangerous elements if you do not control this in trials. So just a brief example. If you have a pulp capping A and a pulp capping B, the expert is saying, okay guys, I will suggest that you do the pulp capping B, and you will have a nice evening. Do the pulp capping B, but you can all see in reality capping in the group of B might not even have been necessary, because, well, you could easily have excavated that without making a perforation. So, okay, you are perhaps doing, in reality, it could be a trial where we say, okay, now we compare class 1 with class 2. But we should know the conditions behind that. And it should be the same treatment. And then we compare the material that we are using. So it's important to be aware if we have prognostics variables that is uneven distributed. We can easily control this by having inclusion criteria, and we can decide whether only to cap the deep ones or the shallow ones. But important is to control the even distribution. Power statistics we have already talked about. The randomization is also important. If you have an inadequate randomization procedure, you might have a problem. Just a small talk in Copenhagen. The university is lying just across the hospital, and you know, the nurses were saying, oh, the doctors, they looked through the letter, through the mirror. What is happening? And they were actually running a multi-center trial doing randomization. And they were trying to get the treatment option in advance. And I have tested it. You can actually illuminate the envelope and see what is written inside without opening the envelope. Now this is tending to be old stuff because now we are doing it by computer. But a lot of bias may be gained and hidden inside trial designs. We did a central randomization and did a phone connection. This is a phone, guys, if you don't remember. And then it was immediately concealed and you couldn't make a new choice for the randomization. Quite important. If you don't have this control, you easily, without knowing it, make overestimation of the test intervention. Blinded evaluation is always a problem in our world. You can make a blind pulp cap and a blind pulpotomy. I mean, that doesn't make any sense. But here we have some suggestions for trials that we need to do. We need to compare the interventions in between. We have had a huge tradition comparing materials, but we may also have an interest in comparing the interventions. And you can have various distribution of that, of course. And you also would like to compare pulpotomy with pulpectomy, and so on. So I still have time? Okay. Because when you was like that, I was a little bit stressed if I should stop. Sorry, no. But again, the deepness of the carious lesion, if it reflects severity in the pulp, and it does. Deeper the carious lesion is, the more you can expect of inflammation. It should be possible to suggest that if you have less advanced lesions, you may only need less advanced treatment approaches. And as it progresses, you need to be more sophisticated. I mean, we need to show this. But we don't know, and that's why people are doing various treatments on the same indications. So in terms of unanswered questions, carious lesion depths, we need perhaps to score them in carious research projects. I haven't talked at all about pulp inflammation, but stay in the room. The next lectures will talk about that, no problem. What should we cap? Well, again, needed research, which treatment material is the best, but let's try to think a little about the type of intervention as well. Comparing those has not been that traditionally performed. So you can always find a quick and dirty table where we switch the pyramid of evidence, and we can say we already have guidelines because we need to teach in our schools. We need to, of course, provide. Remember that even though if we don't have a randomized clinical trial, it doesn't mean that we do not know anything. We then just have to step down in the pyramid, and we just then have to say, okay, now this is the standard. So lack of high evidence doesn't mean that you can do whatever you want to do. And that is also very important, and that is the essence of what we are doing in the university when we are teaching and we are updating the guidelines. Of course, we need to have the front knowledge visible, and that is what is going on in our guidelines. So I'm starting to closing down. You know, it takes time making trials. I know you're aware of that. And actually, it also takes time to make textbooks. I have to say that Liselotte, I don't think she's here today, but John Whitworth is here around. We are very blessed that we got the option and the blessing from the former editor group of bringing this textbooks further. And if you don't know it's around, it is around, and maybe you want to use it. You could also choose the old one, but compare them and see what you like. Well, exposing the pulp is a problem if you don't have the knowledge and tools. Thank you.
Yeah. Okay.
Going to introduce the second speaker is Luc van der Sluis, of course, who needs no introduction in this part of the world, not specifically in this building. Luc's older than that. The building before in ACTA. Spent a little bit of time in France and then back to University of Groningen in the east. Northeast. Northeast of Netherlands. Very much the northeast of the Netherlands, okay? Luc's got a wide range of research portfolio. There is an active interest in clinical trials in cariology, and as Lars indicated, with a particular focus on relating treatment aspects to symptoms. So a little bit different to what Lars was talking about. So without delaying further, the floor is yours.
Well, thank you for the nice introduction, and the organizing committee, thank you very much for the invitation to discuss. I try it again. To discuss with you a paper we wrote and presented.
Okay.
Is the microphone, yeah?
Microphone out. Okay, try it again.
Still.
A little bit of problem.
And I can try first this one. Okay, so I would like to thank the organizing committee for to invite me to discuss with you a paper we wrote, or not a paper, an editorial, with a small group about pulp treatment or vital pulp treatment. We are, as human beings, we are storytellers, and we tell stories, and we also believe in these stories. So that's why we build these great societies. And also when we work at university and talk with our students, we also tell them different stories. And the good thing about working at the university is that normally you work with a lot of smart students. So these students are going to ask you questions. And then you realize sometimes it is not so consistent, the story you're telling. That is also the case for the vital pulp therapy. And that's why we thought, okay, we need to think about a way how we could continue with our research and how we could continue with knowing a little bit more about our treatment protocols. So the questions I would like to address is, does Carious Progression or pulpal diagnosis determine the treatment of the vital pulp? So Lars already introduced this. When do we leave the carious tissue to protect the pulp? So basically, do we leave carious tissue as a pulp protection? Or do we need to remove everything and act as a kind of pulp engineering, so that we can do in a very sophisticated way partial pulpotomies, complete pulpotomies, using with magnification, so that you can do it the best as possible. So I agree completely with Lars. Pulpectomies or partial pulpectomies are not in itself really easy procedures to do. I think you really need a microscope or magnification, and it needs some skills to perform them quite well. So, or is it both? In some cases, can we leave the carious to protect the pulp or the carious tissue, and in other cases, do we need to act as a kind of pulp engineer? Is the irreversible reversible, or is it really irreversible? We all know the cases. Also, Lars already showed that the pulpal diagnosis was irreversible pulpitis. Still, some kind of treatment has been done, partial pulpotomy, full pulpotomy, or pulp capping. and the pulp survives. So there is a big possibility, there is a big regeneration possibility of the pulp. And if the irreversible is reversible, how do we diagnose and how do we treat the different stages of the pulp? So this is the editorial, a small group. We wrote the editorial and we wrote it not as being the truth, let's say, but as start a discussion on this topic and start a discussion and to try to build up networks to continue research. Basically, I started with let's say, an article, Preventive Endodontics, together with Linda Peters and Edwina Kitt and Peter Gruithuizen. Also William Waters is on this photo. As a lot of you know, Linda unfortunately passed away a couple of years, but we can continue her work. So we started on this topic because we were working on deep caries protocols in the University of Groningen. We both worked for a couple of years together at that university, and working on these deep caries protocols, we thought, okay, we need to do a little bit more, and we need to know more, and we need to do more clinical studies. Now, in cariology, basically what they say, or what Edwina Kitt said, and what is, I think, now normally accepted, is that the activity of the Carious disease is in the biofilm. And the biofilm dictates the Carious process, and the Carious process is a kind of interfere, so you have remineralization and demineralization together. But it is orchestrated by the biofilm, and the biofilm can change from person to person, from tooth to tooth. So also in one lesion you have a different activities of the biofilm, but also a different activity of the Carious process. You can have arrested Carious and active Carious in one lesion together. And for the treatment of Carious, it is removal, disturbance of the biofilm, or when you seal the biofilm and you close it off from nutrition, the Carious disease stops. And that's completely accepted in cariology. So when you seal the biofilm off, Carious disease will stop. Now you all know these images. This is an active lesion. And if the patient can change something in his hygiene and brush the lesion regularly, it can develop to an arrested lesion. So basically in the cariology they had a big paradigm shift from extension to prevention to prevention for extension. So basically we want to have a minimal invasive treatment procedure in cariology. And what we started in Groningen a randomized controlled trial working on sealing cavities which normally you should drill and fill. So we have a randomized controlled trial in different clinical practices doing both therapies, and we will see what will be the future. So but we choose the prevention for extension. In Caries Diagnosis there is a system, the ICDAS system, probably you already know, but I think it's good to discuss. International Caries Detection and Assessment System. It's validated to detect the lesion depth of the Carious lesion. Also possibilities to detect or the activity. You have different criteria systems for this. So this is how it works. So at our school we work with it in the periodontic department already for years. It works really very well. In the clinic it's a little bit more difficult to implement. So we're now working this year on implementation in the whole clinic for this detection system. We also have the ICDAS Runcheon score. So basically my suggestion would be, if we treat deep Carious lesions and if we do research, why not use the systems we already have for our clinical research? So let's say for the deep lesions, you could use the clinical ICDAS 5, 6 or 4. You can add the Runcheon ICDAS, active or not, could be a possibility. and then with reversible or irreversible pulpitis. So it could be a help to use an international accepted scoring system. Then I would like to discuss with you a paper appeared in 2016 from cariologists around the world. And basically they accept it now, and that's good news for us, at least for deep lesions, when the lesion was until the inner 1/3 or inner 1/4 of the dentin towards the pulp, even with the risk of pulp exposure. Selective removal to soft was the treatment possibility advised, strong recommended, or the stepwise removal. So basically this kind of treatment, selective removal to soft, where you basically protect the pulp because you don't remove so much carious tissue and you can prevent pulp exposures, could be a good alternative for our, let's say, treatment of deep caries. So here's what they advised. In deep lesions radioclavrically extended into pulpal third or quarter of the dentin, in primary and permanent teeth, selective removal to soft should be performed as a strong recommendation. In permanent teeth, stepwise removal might also be an option for deep lesions. And selective removal to soft, so that's basically the periphery you clean well, so there you remove until hard dentin, and towards the pulp you leave soft dentin, soft carious dentin. The stepwise excavation, now you all know, but I just summarize it. You do it in two, you remove the carious tissue in 2 steps. The first step, you leave soft tissue close to the pulp, the periphery hard, and you place a temporary restoration. Second step, re-entering and remove the carious tissue until firm. Or you have a risk of pulpal exposure in the second step, so more than removal until soft. Treatment cost, because you have to do it again, you have to do another treatment, and there's an extra burden for the pulp and the patient because of the second treatment. Basically, there are no restorative complications until now, what we can see when you do the removal until soft. So when you leave the soft dentin in place, there do not seem to be restorative complications. And there are different outcomes in vitro, but it seems no difference in vivo. So basically, there are no reasons not to perform the treatment. And this is a little bit related to the indirect pulp treatment described by René Gruithuizen. It could be that René left a little bit more soft dentin. That's a discussion I had with Ralf Swendike. But if that's the case, we can, my concern, we can adapt to the soft removal to removal to soft dentin as described in the paper of 2016 from the Carious group. But René had high success rate, 3-year survival rate, and a high recall rate. Okay, so basically the soft, we can leave soft carious tissue when we treat deep carious lesions, when the pulp is reversible inflamed. So then we have another problem in research in this field or treatments. What is reversible and what is irreversible? So this is a kind of, I think, a normal definition of a reversible inflamed pulp. It's from Domenico Ricucci's paper. So there's no history of spontaneous pain, mild sensitivity to cold or sweet stimuli. The pulp sensitivity test responds within normal limits or slightly exaggerated. But important is after the stimulus, the pain stops immediately or within a few seconds. Negative to percussion and palpation, and normal periapical condition on the radiograph. So I think this is more or less accepted as a kind of reversible pulpitis, at least as it is now. Then for the irreversible inflamed pulpitis, that's a little bit more difficult. This is also from Ricucci's paper. So he claims severe pain, history of repeated pain episodes. So excuse me, there's a lot of text. Often self-medication, pain could be provoked or spontaneous. Here is important that the after sensitivity test gave exaggerated responses and did not stop after removal of stimulus. So this is quite complete. But you can discuss, is this really irreversible? Because for every paper, probably there's another definition for the irreversible inflamed pulp. So this is from a study of Ascari, and he used irreversible pulpitis as, let's say, when there was sometimes symptomatic apical periodontitis. Prolonged response to cold testing. So only prolonged response is already irreversible. So we can already show from these statements that it is difficult to compare different studies, as Lars already mentioned, because everybody has basically his own definition for irreversible inflamed pulps. Now, does IPT of pulp capping leaving the carious dentin pulpally, can we also use the treatment for irreversible inflamed pulps? Now, we don't know a lot about this. This is a case for a 30-year patient, 30-year apical radiolucency. They did IPT, and now you see 2000. It takes some years, but then eventually there's no pain. Sensitivity test was positive, and the apical radiolucency healed. So there is possibility. Of course, this is a case. It only indicates it could be a possibility. There's one paper, 78. After 2 to 6 years, there's 50% of the teeth were successful after IPT with apical radiolucencies. And a new paper of Ascari, 2018, just published in the Journal of Endodontics. They had one group of indirect pulp capping, and the 1-year success rate was not related to initial clinical pulpal diagnosis. So some of the teeth were diagnosed with irreversible pulpitis included in the group, and it was not different from the reversible pulpitis. But this is only, of course, an indication. It's an indication it could work also with irreversible pulpitis, an indication which we need to research if this is really the case, and for which kind of diagnosis it could help. Now let's go to the direct pulp treatment. For 10 minutes, let's go to the direct pulp capping, partial pulpotomy and full pulpotomy, and let's see what do we know from research. Now we have the paper of Aguilar. Lars already mentioned it. 7 out of 10 studies worked with reversible pulpitis, let's say. These are the data for the direct pulp capping. So as Lars already mentioned, 3 years is a little bit lower than 1 year or 2 to 3 years. There's a lot of different studies. They use calcium hydroxide, MTA. Quality score, the highest quality is 17. So you can see the quality score is not always too good. And the groups are sometimes small, sometimes small, sometimes a little bit larger. Or here 125. But there's a big diversity between the studies. So also this can give an indication that there is a possibility for the pulp to heal or to cope with this procedure. But we need to do a lot of research in the future. Here the same systematic review. Now for the partial pulpotomy. 5 out of 6 were reversible pulpitis, and we see a higher success rate also after 3 years. Quality is not too high of the studies. They use MTA, calcium hydroxide, only indicating partial pulpotomy could work in reversible pulpitis and sometimes also in an irreversible pulpitis. Same for the full pulpotomy. 3 out of 7 were teeth with AP, 3 studies out of 7. Then the weight pool success of these studies, so teeth with AP, full pulpotomy with AP, was 92%. So also here, full pulpotomy could work on a reversible pulpitis and perhaps also on an irreversible pulpitis for the longer time. with high success rate. So there is a possibility that it can work. Only we need to know how it can work and for which cases it can work. Now let's have a look at the new studies. This is from Stefan Simon. He will discuss it the afternoon. 82% after 2 years, full pulpotomy in reversible pulpitis. Partial pulpotomy in irreversible pulpitis cases, a randomized clinical trial, 50 patients, randomization between MTA and calcium hydroxide. Success rate was 85 for MTA, 43 for the calcium hydroxide cases. So also here, partial pulpotomy in irreversible pulpitis cases has a potential to have an effect, a successful effect. Another study, 2 years result, vital pulp therapy, they compared in a randomized clinical trial full pulpotomy and full pulpectomy with each other, around 400 patients. Success rate around 80% for the full pulpectomy and 86% for the full pulpotomy. The mean age was 7 years, sorry. So also here, irreversible pulpitis, full pulpotomy can work for a longer time. MTA, carious exposures. Here we have 52 patients, 8 with reversible pulpitis, 44 with irreversible pulpitis, 14 with AP. 3-year success was 93, clinical radiographical age was 10 until 59. So also here it gives an indication there is some possibility. And here again, irreversible pulpitis, full pulpectomy, 64 patients, 1-year success, 100% clinical and 98% radiographical. How is it possible that in some cases, also for irreversible pulpitis, the full pulpotomy, partial pulpotomy can have an effect? A nice picture, a nice article of Domenico, he will discuss probably this afternoon. Here we can see a deep carious lesion, and this was related to reversible pulpitis. Here, deep carious lesion related to irreversible pulpitis. When we see the reversible pulpitis, we see a small area of necrosis, and here a big area. Probably for the irreversible pulpitis, the area is so small that the bulk of the vital tissue can survive and can heal, can do the process itself. If we have a bigger area of pus here, here we have the question, can the pulp tissue, which is still here and still vital, is the regenerative potential so good that it can heal itself and overcome this problem, or do we need to enter the pulp and do a kind of partial pulpotomy or full pulpotomy? So this will be the question for the future. Can we try to detect these differences so that we know we can do do an IPT, so indirect pulp capping, or do we need to go in the pulp? Now, basically, this will also be discussed this afternoon. Inflammation will not say that the pulp is irreversible damaged, because it's kind of healing a response. And also we have the dentin pulp complex, which is a very important complex for pulp regeneration, but will also be discussed this afternoon. So for pulpal biology is of course really very important in these cases. And the pulp reacts in the dentin with sclerosis of the tubules, tertiary dentin, replacing dead odontoblast growth factors. So it helps regeneration of the pulp by an extracellular matrix. As I said, will be discussed this afternoon. So for the Carious Progression, now perhaps this could be also a nice discussion for today. Is the Carious Progression leading, or is it a kind of indication? But do we need also other criteria? Can we detect what is the radiograph telling us if we have of the carious lesion. Is it the activity cannot be seen on the radiograph. There is always a combination of activity and arrested lesion. And the pulpal health is, of course, regulated by the immune response. And this pulpal health, of course, is very important in determining what we want to do in the future. Do we want to do a pulp capping? Do we want to do a pulpotomy? Or do we want to do an indirect pulp treatment? The health or the status of the pulp will determine also the healing of the pulp. So in my option, it would be helpful if we could create a system in which we could say a little bit more or diagnose better the status of the pulp, so that the status of the pulp is leading on which therapy we need to do. Now then a little bit to the past. We already know keep an apical pulp stump when it is possible, and a very good paper of Wesseling and Walter in 2000. And also some of the picture of Domenico. So it is possible to maintain a healthy apical pulp stump when you have a vital case. So you see in these cases, it is still a possibility. And this is also a case from Linda. So here the diagnosis was apical periodontitis. When she was doing the treatment, it seemed that the mesial root canals had still vital tissue. So when there is a necrotic, when you have a necrotic pulp, you prepare until the apical foramen. When there is a vital pulp, you can stay short because there's no apical biofilm. There's no biofilm in the apical part of the root canal. So also here, this until the apical foramen and this short. So in one tooth, two kinds of treatment, and can that be the possibility also for the future, that one tooth, one root canal, you could do a root canal treatment of pulpectomy, and the other canals perhaps you can place MTA on the vital tissue. Okay. Show you first, but probably you all know the study of Hashem and from the group of King's College. They did a randomized control trial, indirect pulp capping with a glass ionomer or biodentin. But I want to use this study not to completely explain the study because that would take too long. But what I enjoyed very much or liked very much is that they played a little bit around with the diagnosis of pulpitis. So here we have reversible pulpitis. They have two groups of reversible pulpitis. The mild pulpitis and the severe pulpitis. So the mild pulpitis, still mild reversible pulpitis. Still, if there is some lingering of the pain for 15 to 20 seconds, it was seen as a mild pulpitis. And the severe patient took painkillers, and the pain was more than several minutes after taking away the stimulus. So this triggered me and the other group with which you wrote the editorial. So can we work a little bit with this kind of diagnosis? Can we separate or can we diagnose reversible pulpitis a little bit more, let's say, precise? Although we always know that the clinical pulpal diagnosis has also its limitations. Clinical outcome after 1 year was 83%. And in the mild reversible pulpitis, 4 teeth were non-vital after a year. The severe reversible pulpitis, 8 teeth were non-vital after 1 year, indicating that severe reversible pulpitis, indirect pulp treatment, it could be not the treatment of choice. This indicates that in these the pulp needs the lesion was too big for the pulp itself to heal. So basically, what we try to do is to play a little bit around with the pulpal diagnosis. Could we make a differentiation between the different stages, between different diagnosis system, so that it could lead us to a kind of therapy? So we called it the EndoLite, minimal invasive endodontic approach. And it is important, we thought, to maintain biological response of the tooth as long as possible. So keep as long as possible vital tissue within the root canal system to prevent apical periodontitis, improve the success rate of vital pulp therapy, to maintain proprioceptive function of the pulp, and, for example, in some cases, to have to stimulate the apicogenesis. Now, we could also try to save tooth structure and increase, if it is possible, also tooth survival, saving time and costs for patient and society, and reducing pain discomfort for the patient and by a less invasive treatment. And these costs, still, I think, is also an important aspect. When working in Groningen, there are more people who cannot afford dental treatment. So at the beginning I saw radiographs with the molars, and then sometimes 1 year, 2 years later, some of these molars were not present anymore. And then I thought, how is it possible? Because we could do a root canal treatment, no problem. But then it was a problem because the patient could not pay the bill. So we could do two things, do something as a university, or we could say, okay, pulpotomy could have saved these teeth. So for a group of people who don't have money, full pulpotomy could be a good option. But this, of course, is not the only reason, also because we think it is really a treatment possibility. Now, we have a small group which we wrote the editorial, and with which we would like to try to start some clinical work. Now, what is the idea? We have the initial pulpitis, we have mild pulpitis, we have moderate pulpitis, and severe pulpitis. So if you start with the initial pulpitis, it's let's say the classical reversible pulpitis. So you have some response to the call test, but it is not lingering. So you have a response, and it stops immediately after you take away the stimulus. Then you could have a mild pulpitis, so you have heightened and lengthened reaction to cold, warmth, and sweet stimuli that can last to 20 seconds. So let's say 20-30 seconds. So it lasts a little bit longer, but it stops relatively short. And we could hypothesize that the inflammation of the pulp is such that the regeneration of the pulp could heal itself without intervention. So we don't need to enter the pulp. We could do an indirect pulp treatment, and this should be enough to heal the pulp. So this could be for the mild and the initial pulpitis. If we have the moderate pulpitis, so we have clear symptoms, strong and heightened prolonged reaction to cold, which can last for minutes, could be sensitive to percussion, and the patient could take pain medication. So it could be that the lesion in the pulp is too big to be healed by itself. So here we need to enter the pulp. So we need to do a partial pulpotomy or a full pulpotomy depending on the inflammation of the tissue. So we could remove a small part of the inflamed tissue until it doesn't bleed anymore. So bleeding is basically an indication, is the tissue vital or not, or can it heal or not? So bleeding is the only possibility we have. So it could be coronal pulpotomy partially or completely. And then the real severe pulpitis, it could be an option to do here, start already with the pulpectomy, because you know a partial pulpotomy will probably not work. And this could be a possibility, but of course we need to research if this is possible, but it could be a possibility. I think as endodontists we do now a lot of retreatment cases, and we treat a lot of apical periodontitis. It could also be that as endodontists we could treat more deep carious lesions, and we could as endodontists become more pulp specialists, so that you will become a pulp engineering, and could be possible to work, of course we already have the microscope, very sophisticated to treat the pulp, cover it with the best liners there are. And perhaps we can also make a differentiation if we have done the full pulpotomy, which of the pulp tissue in the pulp in the root canals is still vital or not, or which pulp tissue in which root canals we could preserve, yes or no. Of course, this is for research, but it could, in my option, be a nice indication for our future possibilities. Now, we could include ICDAS 4, 5, and 6 with clinical diagnosis, reversible initial pulpitis, IPT, mild reversible pulpitis, IPT, as I discussed earlier. Now, what do we have to do? Gaps in knowledge. Now, we have, of course, enough gaps in our knowledge, and for the network, we need to establish the network, finalize the protocol, setting up the pilots. And of course, it is the organization is really very, very complicated and difficult. I'm also working on setting up a practice-based research network in Groningen, and we have now a very good manager to work on this, because the organization, as everybody knows, is very difficult and one of the most important things. Then for diagnosis, we really need to know how efficient is the system I just showed to you, how reliable is it, improvement in clinical pulpal diagnosis, is it really an improvement, possibility for markers, also for the afternoon, treatment, carious tissue removal, how can we the best remove the carious tissue, what are the best liners, location for carious tissue, already Lars mentioned it, is it occlusal or in the box proximal, what is the effect, pulpotomies, what are the treatment protocols, efficacy, long-term clinical trials, what is the reaction to the pulp tissue, so still a lot to do. So then I would like to thank you, and Vienna is calling, but I think also the coffee is calling. Thank you for your attention.